Hi, everyone. We're just going to give one more minute for people to join, and then we'll get going. Thanks. Right. Welcome, everyone. Thanks very much for joining us. We're going to get going in a second. We're very, very privileged to have Professor Linda-Gail Bekker with us today. I'm sure all of you know her already, but she's a professor of medicine and chief operating officer of the Desmond Tutu HIV Foundation, also director of the Desmond Tutu HIV Center at UCT. And among her many accolades, been involved in some of the biggest and most impressive HIV trials in well, the world really, but from her perch from South Africa, and also past presidents of International AIDS Society. And this is a speciality topic of hers, where the long-acting injectables hopefully will change the face of HIV PrEP and even treatment as well. And we're delighted to have you, Linda-Gail. The usual kind of house rules for everyone else, you can't unmute just because it's way too chaotic then, but you're welcome to type any questions you have in the chat. We encourage that. We'll get to any questions at the end. And then I'll put up a link just at about 20 minutes past the hour for CPD points, which you can click on and enter your details then. I think that's it for me. So welcome, Linda-Gail, and take it away.
Thanks, Jeremy, and real pleasure to be with everyone this afternoon. Hope you're doing okay in the start of our winter. This is really a real privilege for me just to catch you all up if you aren't there yet in terms of where primary prevention is heading in HIV. But, you know, happy to answer other related questions when we get there. So I do receive honoraria for advisories, and you see the companies that I've advised in the past. So we really want to start here, and this is the intractable challenge. Since the 1990s, the incidence for young women and girls in our country has really hardly moved. And this is data that was published by Test not too long ago, looking at the ECHO trial, which was looking at different methods of contraception to see if hormonal contraception had an impact on HIV susceptibility. Just FYI, it did not in this trial, but very importantly also just showed that we continue to see very high incidence rates amongst older adolescents, young women in our country. And this really extends throughout the eastern southern region. So this is another paper recently published by Nora Rosenberg, where she used these fears, these cross-sectional studies done in a number of countries now, most of them PEPFAR countries, again showing that the eastern southern region is particularly hard hit when it comes to young women and girls. But we also see, incidences that don't occur anywhere else in the world, really, in certainly heterosexual men. But increasingly in sub-Saharan Africa, we also have to keep our eye on what is known as the key populations. So these are populations of people who, for various reasons, whether they are risk behaviors or lifestyle choices, are particularly vulnerable to HIV acquisition, but at the same time also have due to policy and laws and a whole lot of other stigmatizing reasons, have poor access to HIV treatment and prevention services. So this is the other group we have to keep our eye on. And typically it is people who transact sex, their clients, gay and other men who have sex with men, and transgender people. So the result is, when it comes to prevention, we are just off track. So this is not where UNAIDS wanted us to be in terms of bringing incident infections down. And we are going to have to do a whole lot better if we really want to meet the 2025. And now, of course, we're shifting the goalpost to 2030. But there's a lot of work to be done to get to a point where we can begin to think that we might have some epidemic control. So very important that we focus on primary prevention. I took out slides to explain why we aren't going to treat our way out of the epidemic. I think this is now well understood. Prevention is going to have to come alongside treatment if we are, in fact, going to make an impact on the epidemic. Now, key to primary prevention at the moment is this notion of pre-exposure prophylaxis, because we don't yet have a prophylactic vaccine. And so we are very reliant since 2015 on this concept of antiviral based PrEP. And then I will, towards the end of the talk, give you a bit of time to immune-based PrEP, or passive immunization with monoclonal antibodies. So this is PrEP generation 1, which involves these two drugs, tenofovir with FTC. They're combined in a single pill. And what you can see from these randomized controlled trials is that we really do see reasonable protection, particularly if, in the case of vaginal mucosal exposure, people are able to take the treatment daily, 1 pill a day daily. We know that there's a little more forgiveness when exposures via the anal mucosa, and there, as long as you're doing 4 or more doses a week, that seems to be very effective. So 2 studies done in Africa did not show protection, but in both those randomized controlled trials, we know that women hardly used the product. So these results came out in 2010. We got FDA approval in 2012 and WHO recommendation in 2015. So we now have some sort of generation 1.5, if you like, because it's burgeoned from oral FTDF to now its cousin, oral FTAF, given daily. We don't have data yet in cisgender women. That is accruing at the moment, but we do know this is as effective as FTDF in men and transgender people. And then we also now know that you can take this drug in a 2-1-1 fashion. In other words, 2 tablets, 24 hours before sex, a tablet 12 hours later, and another tablet 12 hours after that, and you see comparable protection. But again, this has only been shown in men. So the WHO has, it's actually only been shown in men who have sex with men, but the WHO has extended the recommendation to all men. So that's how we look in terms of oral PrEP. We do know that we have not really rolled this out to the extent we should. This is a global epidemic. Many millions of people around the world are at risk of HIV acquisition, but we really are only about 3.5 million people having initiated oral PrEP to date. So still a lot to be done here. You can see the targets are off the charts in terms of where we are and where we should be. Happily, our region is giving the biggest contribution in this regard, and most of it's coming from Kenya and South Africa. Why aren't we seeing uptake the way we should? Well, there's a lack of commitment to primary prevention in the first instance. Funds often don't go in this direction. There's ideology that somehow PrEP will, lead to a great deal of sex, and condoms will migrate, and a whole lot of other anxieties. There really is insufficient demand creation amongst populations. I've already mentioned insufficient investment, particularly in access to all populations, and the price is also a factor. So how are we looking in South Africa? Well, I'm pleased to say, although we started in key pops, which rather set the program back, and then there was a kind of offering hesitancy, we now are beginning to see a scale up of public facilities. And there really was an intention to get going. And then, of course, COVID hit. COVID has set us back a little bit in this regard, but we are now beginning to see in 2022, more than 3,000 sites and 200,000 initiations. So we have our sites really on far more initiations in the country than have occurred up until now. And when you look at our data, it does look like we're reaching the right population in terms of these young women and girls who really bear the brunt of new incident infections in the country. This is where Hasina Subadar and the team want to go in terms of the next year. So again, ambitious targets. And really, it does mean that PrEP needs to be given out by just about every nurse who's available. And one of my current bugbears is the need for a NIMART trained nurse, where obviously this is a commodity that should be given out, if you like, almost like jelly babies. One of our problems is persistence. So people start PrEP but don't really keep going. And you can see these are the technical working groups, rather, I think, pessimistic viewpoint of what that the persistence will be in the population, and this is how they've modeled their data. So really quite dismal persistence predicted. Obviously, we have to try and improve that if we can. This is an interesting paper. I just want to throw it out there because I think we don't want to forget men in our populations. And this is data coming out of Kenya, but showing quite nicely that whilst you get your biggest bang for the buck amongst women 15 to 24, where resources are available, you should include men, because this also brings in some benefits. So I think you don't want to forget men if possible. And of course, I've already mentioned key populations as an important group. One of the ways we can counter this lack of persistence and perhaps a lack of adherence, if you like, although we don't like to think of adherence when it comes to PrEP, we like to think of the concept of effective use. In other words, people need to discern when they are at risk of HIV exposure and then make sure that they've got their PrEP on board. How do we improve that? Well, the WHO has now moved us to this concept of differentiated service delivery for ART and differentiated prevention delivery for prevention. So here we think about the when, the where, the who, and the what of PrEP. And we really tried to demedicalize, simplify, integrate with other sexual reproductive health services, and of course, differentiate for the populations we're serving. So this really helps us to think how we do this and move a little bit away from the model of pure facility-based. So we've done quite a lot of work in this regard, and this is work from one of our PhD candidates who went out and asked young women where would they want to get their PrEP. And we heard everything from, I want it to come to my door, I want to find it in shopping centers, I want to pick it up in pharmacies, and I want to pick it up in the community, for example, in mobile trucks. So we said, well, this sounds like fast food. Fast food is fun, it's easy, it's accessible, it's cheap, there's variety. How do we make PrEP look more like fast food? And we have now devised, with some funding from Bill and Melinda Gates, this hub and spokes model called Fast PrEP, where young women and girls and their partners and young MSM and transgender people in a single sub-district can initiate on a mobile or in the facilities, in the health facilities, and then their follow-up can be in this variety of different spokes. And this experiment is underway at the moment, and I'm happy to answer any questions, but we're doing everything from couriering their tablets to them, allowing them to pick up in schools, to pick up in depots, at hairdressing salons, in taverns, etc., to see if we can increase persistence. So I think we've learned a lot of lessons from this first generation of PrEP. We've recognized that it's very important. It's not just the product, it's also the approach whereby it is delivered. We recognize we have to increase demand generation. We've been very bad about doing that, really throughout the HIV epidemic, throughout health, I want to say, but also in this country, in terms of getting people to understand that this is available. That we need to also think about service delivery models. I've mentioned what this might look like, integrating also with other sexual reproductive services, and where possible, having community-based approaches. Okay, one of the other ways we can improve PrEP persistence is, of course, to move towards longer-acting, less frequently dosed opportunities, and that really introduces the second generation of pre-exposure prophylaxis. But it also needs to be said, alongside the less frequently dosed is this concept of choice. So if we can use contraception as the paradigm here, we know that once we introduce more choice to women, we had better uptake and better pregnancy and fertility outcomes. So it's this concept of giving women choice where they can choose a method that suits where they are. So I'm pleased to say that that is starting to happen with PrEP as well. And we now can add the dapivirine vaginal ring, which is a monthly ring, and we can add the cabotegravir long-acting injectable, which is a 2-monthly injectable. But let's go through this with a little more detail. The dapivirine ring is it is a silicon ring which is infused with a non-nucleoside reverse transcriptase inhibitor called dapivirine. It's not being used in treatment, of course. It's a bit like a brick, and there's very little systemic absorption. This acts topically within the vagina. It's placed right up near the fornix, around the cervix, and 2 randomized controlled trials showed rather modest results, around 30%, but in their open label extensions, we saw that risk reduction go to 50%. This led to the EMA saying, right, we can let the WHO recommend this to women in low and middle income countries as a second line to oral PrEP. The third sort of option that is now out and very exciting really showed better results in randomized controlled trials. This is cabotegravir. It's a strand transfer integrase inhibitor, a cousin, not a it's not exactly the same, but a cousin of dolutegravir. It has a very long half-life. And once put into this injectable, can be given 2 monthly. So there were 2 randomized controlled trials, one in cisgender men and transgender women who have sex with men in the Americas, and one site in Cape Town, showed very nice results, about a 0.34 hazard ratio. And then HPTN 084, which was conducted in Southern Central Africa, Eastern Africa, showed this unbelievable 89% reduction in HIV acquisition amongst women having sex with men. So really the best results we've ever had in a randomized controlled trial. And in the open label extension, this has just got better and better. So these are women who had high STIs, definitely at risk for HIV acquisition, but showing incredible benefit from this long-acting agent. Now the whole question of access comes about. And I just want to reflect for a moment on a study, a modeling study we did with Rochelle Walensky way back in 2016, where the conclusion to this modeling study was currently available PrEP is a cost-saving intervention. The delivery should be expanded and optimized. Long-acting PrEP, and we didn't have the results then, is likely to be very cost-effective, but may require novel financing mechanisms that bring short-term fiscal planning efforts into longer-term societal objectives, and never a more truer word in that regard, in that we, really are now in negotiation with both PEPFAR and the Global Fund to say, can we bring this, at this point, quite expensive pharmaceutical to all the parts of Southern and Eastern Africa. There have been other modeling studies, fast forward now to 2022, showing that probably we need to get the price down, and it's likely that we need it no more than twice the cost of oral daily therapy for it to be really a viable proposition. So we are not there. But clearly there is benefit over the fact that it seems that we get a better hazard ratio with this modality. The downside is going to be, can we afford it? And again here, that study from Jameson, Smith, others, showing that the impact is likely to be substantial. We'll see HIV incidence coming down. There is a concern about, will we put integrase inhibitors at risk? And of course, that's always the tussle with pre-exposure prophylaxis and treatment. But it does look like, you know, if we can reduce the number of infections around the world, overall, we will see an impact on mortality and morbidity. So very important. And I really am not going to go into all the details. If you're really interested in this, it's a well worth modeling study to go and have a look. But here in this study, they're saying we almost need to have it at similar pricing in order for it to be effective. So what is the price point? Well, at this moment, we really are looking in terms of the pharmaceutical company has put it out at quite a high price. They have worked with Patent Pool now to give the license away, and some of you might have seen that Cipla was announcing earlier this week or last week that they will start making this. I suspect it's a fill and finish to begin with in Benoni, but ultimately there are 3 generic companies now that have the patent to start moving to making this. My understanding is it's not easy. There's one factory at the moment in the world that makes this kind of long-acting agent. So I guess we're just going to have to watch this space. Like everything, we're going to get the best impact if we can get it out. And of course, this is where the rub, you know, hits the fan, or whatever the saying is. We are going to, you know, really not be able to get this out at current prices unless we have donor opportunities to bring it in. So the first step, of course, always is pilots. And this is a busy slide, but just to show you where the pilots are going to begin. They are very much in Eastern, Southern Africa, a little bit in South America, but really there is very little cabotegravir LA available immediately for us to do these pilots. So we really are talking about minimal amounts of CAB-LA in the first instance. And this is my very simple modeling data, which says we've got to bring the cost down in order to see the coverage go up, in order to see impact. And it's the generic formulations that are going to help us do that. And it's a question of how quickly we can do that. There is a group who, together with Bill and Melinda Gates Foundation, the WHO, and others, are looking at ways we can increase access. And besides, you know, voluntary licenses, pilots, donor funding, all available opportunities are being looked at to see how we can get CAB-LA further out as soon as possible. These are where the pilots are going to be for your information. So there are a few in KwaZulu-Natal, Johannesburg, and then Cape Town, as you can see, with one opportunity in the Eastern Cape. Yeah, so, you know, not vast and probably very slow beginning. What are some of the concerns we've got to learn about in terms of, implementation science and pilots as we move out? Well, the big question is that long tail. So cabotegravir, you introduce via an intramuscular injectable, and then, of course, it takes a long time for the pharmacokinetics to wash out. And we were all very worried about people walking around with low dose CAB on board and possibly exposure to virus. It turns out that what actually is worrying everybody more now is that you can mask acute infection by giving somebody an injection of cabotegravir whilst they are seroconverting. And then those individuals get missed and lost. And we saw most of this coming out of the men's study, HPTN 083. We have seen a couple of cases in the women's study. So this raises the question of how do we test, how do we ensure that people are negative at the beginning? And the FDA has come out with a recommendation that actually antigen testing, nuclear antigen testing should be done at initiation. Now that adds an enormous cost and an access issue. And so the WHO, it is our understanding in their guidance is going to be a little more permissive in this regard. But obviously this is a piece of science we need to answer. There are other things we need to learn. Is Cabolet safe in pregnancy and breastfeeding people? Are there other DDIs? Of course, the rifampins are always there. Who uses PrEP, when and why? Who switches? How often and why? How do you switch? How do you stop, restart? What are the other gaps we have to learn about? Does this re-medicalize us? So I spoke to you about how fast PrEP, we're giving the tablets out by Uber at schools, in taverns. Will this drive us back into clinics where a nurse will have to, give the intramuscular injection? And how will we upskill all of these nurses? And how do we educate users? And what is the science of choice? How will people be able to make the choice around whether they prefer oral to injectable towards ring? So I think there are some very key areas of implementation science with each of these modalities that I think keeps the field very exciting and much work to be done. So what other innovations are there in the pipeline? I think it's useful for you just to catch you up. This is not the end of the road. But in fact, there is a burgeoning number of longer acting interventions as well as shorter acting interventions. So there are also coming douches, films, things that can be used once off for coital exposure, as opposed to these even longer acting injectables. And I'll come back to that in a moment. But let me digress momentarily around the monoclonal antibodies, because we have got a randomized controlled trial that has shown that this concept can work. So I just want to catch you up on this data. And this revolves around two randomized controlled studies called the antibody-mediated prevention studies. Again, one done in amongst men who have sex with men and transgender people in America and Europe, and the other one amongst women who have sex with men in East and Southern Africa. And the concept here was to take a single broadly neutralizing antibody known as VRC01. It locks onto the CD4 binding component of the virus. And this monoclonal antibody was then administered in 8 weekly intravenous infusions. Now, I was a great doubter that this could ever be pulled off. I had 2 sites for this study. I'm amazed at how people showed up for their infiltrations. It was extraordinary to see. And again, we really had very good retention and protocol compliance in this study. Unfortunately, what we learned is that it was effective as long as the virus that infected the person was sensitive to VRC01. In other words, as long as the antibody matched the infecting virus, we had good results. But the minute that the virus had evolved and looked different to VRC01, we found resistance. So overall, we did not see effect. But in these sensitive viruses, we saw effect that really says to us that if we either provide a cocktail of these monoclonal antibodies or we have a trivalent, a little bit like antiviral therapy, we have triple therapy, we are more likely to get a good result. And of course, the world is moving in this direction. We have happily a pipeline of these broadly neutralizing potent antibodies, which are now being mixed and matched and combined and so on. And these studies are beginning to happen to say, can we prevent HIV if we provide not one antibody, but triple antibodies, which give us better breadth and depth. And here you see the nice sort of slew of broadly neutralizing antibodies coming in, and there's a variety of phase 1s and 2s beginning to happen. So those of you who are skeptics will be saying, oh, please, monoclonal antibodies, are way out of our league. And it's true. We have been denied on this continent and in LMICs the wonderful new medical innovation around monoclonal antibodies. And I'm hoping, as has been the case with HIV in the past, that we can create some impetus around this, because there's no doubt that, we need to move more monoclonal antibodies into the realm of the LMICs for oncology, for rheumatoid and autoimmune diseases, but also for infectious diseases. And, as I've mentioned, there's no doubt that we are being restricted at this moment. So when you look to see where are the monoclonal antibodies, they are sitting in the first world, and we are not getting access to them. And I think, this is something we need to take on board. I now, have a role in a wonderful foundation called Access to Medicines. There are other very important groups really looking at this inequality around the world to say, how do we improve things? So here, rather dismally, if we just take Nigeria and Zimbabwe and compare ourselves to the EU or the US, it's clear that we really are on the downside. And again, in infectious diseases, again, very dismal. So I'm hoping all of you will begin to think, how can we create more advocacy around this? You can see rabies being just about the only condition that benefits from monoclonal antibodies. If we did have RSV monoclonal antibodies at an affordable price, there are many neonatal lives that we could save. So again, an important part of medicine to be advocating for. And IAVI and Wellcome have been writing some great publications about this recently, and I'm just wanting to make you all aware of that. In the interest of time, I'll keep moving on. So you hear this is a soapbox I have at the moment. But let's look at the other longer-acting prophylactics in the pipeline. This is a very exciting drug and a very sad story. So islatravir is a drug with a novel mechanism of action. It's a nucleoside reverse transcriptase translocation inhibitor. Again, very potent, very long half-life. We had great hope looking at its half-life that we could administer this as a very small pill once a month. We did the phase 2. We're moving into the phase 3s, and in fact had started the phase 3s with a lot of excitement when a very unexpected lab abnormality occurred. We did not see any clinical reasons, but we had to suspend the studies because of this drop in lymphocytes and particularly CD4 cells. So islatravir was also in a treatment program, as well as the prevention programs. And you can see here the range of different studies being taken on. Happily, as I say, although the lymphocyte subsets came down, we did not see any clinical reason, or problems in both of these studies, but it was felt, particularly by the FDA, that the company had to go back to the drawing board. So they have come back in a lesser dose. And so the treatment studies are back underway at a lower dose of islatravir, and those will go on. But the pre-exposure prophylactic program has actually been stopped. So we will not be moving forward with islatravir as a monthly pill. The implant, because it can also be an implant, is on hold, but is likely to resume. And then there is a close cousin called MK8527, doesn't yet have a name. It is being moved forward now. So it was a little behind islatravir. That's why islatravir was chosen. It doesn't seem to have the same lymphocyte problem. And so that study, that particular agent will move forward. There is another very exciting long-acting injectable. It is an HIV-1 capsid inhibitor. It's known as lenacapavir. Some of you may have heard that it is already approved for people who need salvage therapy. It has a it's very resistant to resistance. And the great news is you only have to take it 6 monthly. So it's an injectable that is given. It's given subcutaneously, so it is open to self-administration, and it is a 6 monthly injectable. So as I mentioned, higher resistance barrier, novel mechanism of action. The question just is what to pair with it. And some of you might have seen a CROI that it is being paired with monoclonal antibodies for treatment. So quite exciting, but there was also work to pair it with islatravir, and that study has now resumed. So lenacapavir with islatravir. It is, of course, excellent for prevention as a single agent. And those trials are underway. They are known as PURPOSE. This is PURPOSE 1 amongst women and girls. Here it's very interesting. We have also introduced FTAF as a secondary endpoint compared to FTDF orally, to get that data on FTAF, because you'll remember at the beginning of my talk, I told you we don't have data on oral FTAF as a preventive in young women and girls. So this study will answer that, but it will also look at lenacapavir versus FTDF. But the primary endpoint is actually background incidence. So it's a very interesting new design being allowed by the FDA, and I think very exciting. There is an equivalent study among cisgender men, transgender women, men, and gender non-binary individuals. And you can see here that this is FTDF compared to lenacapavir, and again, background incidence as the readout. There are very exciting other options in the works, such as dissolving microneedles, and you can see a variety of drugs being looked at, as well as implants. And these implants we're hoping might be able to go on for a year at a time. So again, exciting. Finally, what is, besides this wonderful pipeline, which you see, there is also the hope that we can combine some of these actions together with anti-STIs and contraceptive mechanisms, because sexual reproductive health really does need to be integrated at every single level. And to this end, these multi-purpose technologies are coming through the pipeline, most of them in the form of a vaginal ring, it must be said. But here is one, the first to get into the field, which combines a hormonal contraceptive with FTDF as HIV prevention. And so this is being developed by Viatris, and this study is in the field. So here you see, you know, the whole pipeline, as well as the concept of MPTs coming down the pike. When we think about these new products, we have to think of clinical aspects. We also have to think about policy and programs such as delivery channels, the health system burden, the cost, of course, and then there are some personal aspects such as user effect. Remember, these are healthy individuals who really have, you know, places to be and things to do. And so we have to think about our prevention methods as something that is going to fit into their lifestyle. So when we want to accelerate new prevention options, we really have to think about those who use, those who choose, and those who pay the dues in terms of, you know, how we're going to get to this. How do we get this out to where it needs to be? And so taking new products to scale means translating biomedical options into viable choices. So again, we shouldn't forget about demand creation. We should think about the delivery models and other key implementation science questions. Civil society has to be involved. How we fund and pay and procure these things is absolutely key and critical. Training our healthcare providers, also very important. And then, of course, trying to be as much as possible equitable is no small task. So I will end by saying, here is my prediction over the next 5 years. It's not rocket science. I think obviously our treatment efforts have to continue, but it is going to get harder. The last mile is always the most challenging. So as we move to, apparently 95, 95, 95, it is going to get harder. We will see steady ongoing increases in oral PrEP use, particularly as we improve our delivery models and we start to talk more about pleasure rather than HIV risk. And I can talk about that for 6 hours. We will see the introduction of choice, but that unfortunately is going to be slow. The vaginal ring is now coming into country, but even that is quite pricey. At the moment, the Global Fund is procuring it for us. And Cabalet will come in variously through implementation science and donors, as well as PEPFAR on a very small scale. We will also get a better sense of market share and population preferences and the reasons for switching as these pilots begin to evolve. And of course, I do think there is still a gap for a less frequently dosed pill. Once a month would be terrific, as well as non-antiretroviral immune-based prevention, and ultimately, of course, an effective vaccine. And with that, Jeremy, I will stop sharing. Thank the people who, give good data over time, and happily answer any questions.
Great. Thank you so much. It's a real masterclass and a privilege to hear. Lots of comments have been sent to me on WhatsApp and on the rest. I'm just going to go through some of the questions really briefly. Maybe just to start with a question about what we have at the moment, this oral PrEP. It hasn't been rolled out nearly to the degree we'd hoped, I think. And I mean, do you think there's been enough demand creation? I mean, where do you think the big block is? Because I'm not sure many of the people who would be eligible will even think of it, really.
Yeah, I think, Jeremy, I think it is always the push and pull, right? So the push is demand creation. Let's make it sexy. Let's make people aware. Let's really get to everybody so that there isn't a stigmatization around it. But then the product itself does have some issues, right? It looks like ARVs, sounds like ARVs. It comes in a pill box that, really does seem to be antiretrovirals. And to date, we've only given it out in facilities, which really underpins. And it's got to be a nurse who happens to be a NMART nurse. So, we couldn't make it look more like an antiretroviral therapy. And that clearly has stigmatization issues. So I'm very much for the seroneutral approach. If we can, let's even destigmatize antiretrovirals if it comes to that, But in the meantime, can we get it out into the community? So I will tell you what we've done with Fast PrEP, and this comes with funding from Gates, God bless them, is we've actually got a marketer. So this marketer normally, she was selling Moët champagne, and now I said to her, whatever you did there, come and do this for PrEP. And she's really applied the same principles. How do I make this something everybody feels they need to have? And it's made a huge difference. It really does. People start to say, well, hold on, maybe this is something. Obviously, amongst adolescents, we've all probably got adolescents, or maybe we remember being adolescent not too long ago, is it's quite hard to do something daily. So this is where we fall down. And we know this from oral contraception, or anything for that matter, or, oral TB treatment. So if we can get options for people who struggle to do something daily, but don't mind an injectable, and then somebody who doesn't want a needle or a pill could maybe think about a vaginal ring. So, we're starting to be able to administer choice, I think will make a difference as well.
Agreed. Lots of questions about the sort of the nitty-gritty of some of the cabotegravir components. So maybe I'll just take them in groups of two. So that one is about, you did mention it, but just if you want to maybe reference it again, the rifampicin drug-drug interaction with cabotegravir, and how important do you think that is with injections?
Yeah, I mean, it's going to be an issue, right? With dolutegravir, we have been able to, get around it. The cabotegravir at this moment, I think the recommendation is going to be not to use it in people who acutely have tuberculosis. So I guess you could argue maybe, if you're in the first 2 months of your TB therapy, you maybe shouldn't be having, wild sex. I don't know. I mean, at the same time, You know,
Sure.
this raises the question of whether we shouldn't be, you know, being careful about which agents we develop for LMICs, because TB is a way of life for us, right? But the recommendation is going to be to avoid in
Sure.
acute tuberculosis.
And, and obviously, as you said, it's just temporary. I mean, you could move on to oral, PrEP for that time and then move back afterwards,
And the vaginal, if you're a woman, it has very little systemic absorption and seems to be absolutely fine. There, the downside is our NNRTI background resistance, right? So are you going to get infected by, an NNRTI resistant virus? That is the other down. So none of these are perfect, right? But in my book, a whole lot better than only having condoms available. But it is important that we still keep the other prevention methods available and alive and well for people. So there will be individuals who, have to resort to latex condoms, and that needs to continue to be available to those individuals.
Agreed. And then there's a question about how to dose the cabotegravir. So it's 2 monthly, but the question is about how to start it. Do you need a loading dose? But I mean, and I guess then maybe just talk about the first 2 doses. Yeah. Right.
So the detail is you give a dose and then a month later another dose, and then you move to 2 monthly. That we were doing an oral lead-in that doesn't have anything to do with the PK. It's purely for tolerability and, ensuring side effect. In fact, most people around the world now are skipping that. And the recommendation actually in the package insert is you can use an oral lead-in if you wish, but it is not required. So it's really for the provider and the user to make that decision. The pills are available, but it's not a requirement, and it doesn't in any way help with loading. It simply shows, shows tolerability. And for many people, it's kind of a wasted month, because if you're struggling with pills, you want to get away from the pills as soon as possible.
No, agreed. It certainly makes it a lot simpler. It's good to see it doesn't appear to be necessary. And then a question about how many mils and basically really the injection site itself. Is pain and nodules a big component of the side effects?
Yeah, so the greatest adverse events were around injection site reactions. Interestingly, all the studies, Atlas, Flare, they have all shown great acceptability, but you have to always bear in mind these were individuals who signed up for an injectable study, right? So presumably they didn't have strong feelings around injection pain. Having said that, there is in all of the studies a small percentage of people who just stopped using because of injection site. None, doesn't seem to be a major, it's more the pain, and it seems to subside over a few days. It is quite a big injection. It's a couple of mils. It goes into the top part of the gluteus, and so it's got to be given by, I think, a trained administrator. It definitely, in my opinion, cannot be given self, into that muscle. There was a study that was shown at CROI of self-administration into the thigh muscle, which apparently was possible, and, a small study that did work. I think I would hold out for lenacapavir if that was the way to go, but of course we don't yet have that data. So again, I think the pilots are going to help us understand that potential. And of course, for those of you who are treaters, and I know probably the large majority of you are, we've got the injectable treatment or Apretude also coming through now, or Cabenuva. So rilpivirine with cabotegravir, which is obviously even a greater volume because you get one injection in the one bum and the other injection in the other bum. People seem to be tolerating that as well. So, I think if you're really struggling with pills, this is an option. And what people are telling me, just to digress into treatment momentarily, is that it's worth it to just forget about treatment for 8 weeks, to forget that I have HIV. And I think perhaps this is also around the pre-exposure prophylaxis is, I keep forgetting the pills. Now I can just forget about it for 8 weeks and just be reminded 6 times a year that I'm due. The big thing I would say about preparing people, just going back to that loading dose, is people must understand that it's a long-acting agent. And it's not, with PrEP, oral PrEP, I get the real feeling people are just giving it a try. And then if they're not liking it, they're not coming back. You can't do that with a long-acting injectable, right? So we've really got to understand that people get it, that this is a relationship with the product for a long period of time, because obviously if they don't come back, you're going to have to convince them they've got to go into oral PrEP for a time to cover that tail, which is how we've run the clinical trials to date.
And I think with injection site reaction, I think it was true in the treatment and the prophylaxis, PrEP trials, that most people tolerated it better as it went on, I think, right? There's a minority who don't.
Yes, yeah. Exactly. No, that's exactly it. I think, I think and think about it. Often it's the stress and the anxiety about the injection that makes things worse, right? So a buttock muscle gets tense and then it's more painful. It's quite a big volume. So if you can be relaxed, and obviously as time goes on, as you become more familiar with it, that relaxation helps. There are definitely knacks to this. We've got clinicians now who are just brilliant at giving those injections as well. So I think you also want to go to someone who's used to doing it, and is good at administering, which helps. And this is our other big fear is, will we re-medicalize now that we're just beginning to differentiate prevention? Is it going to drive people? So that fast PrEP program of mine, we are offering Cabernet and we are offering the vaginal ring. And it's going to be very interesting to see how people choose and how much the delivery method enhances which one they choose. So, I really love having my PrEP Ubered to me. Therefore, as much as I want Cabernet, I've got to stick with oral PrEP or a vaginal ring, because you can't Uber an injection, right? Yet, maybe one day, but not at this point. So there you are. Yeah.
It's really exciting study. I mean, I can't wait to hear more of it as it's further along. It really sounds so cool.
So I will tell you the numbers. We're heading for 25,000 people. So the idea is also scale. And so it's a health sub-district, and our N is 25,000. We've now got to 8,000. So we've still got a ways to go.
It's really big scale stuff. That's impressive, really. And then just last couple of ones, I think you did kind of allude to it, but there's a question of, are there reports of injection fatigue? I mean, I think you said the problem with the trials is that they obviously signed up for the injection, but has there been sort of much real world experience with that? Do people drop off at a reasonably high rate, or how's it been?
Definitely better than the pill, right? So I just want to be quite clear that, particularly in this region, we are quite regularly seeing drop-off rates of 30 to 40% retention after 6 months, right? So a third remain. So really quite dismal in that regard. And the injectable is just better, and as I say, maybe because we're also really hitting hard on, you have to come back, you can't be out there in the wilderness. This is not good.
Yeah. And then last question was about Levi syndrome. You mentioned it in the trials. So perhaps you want to tell the audience what it is, but the question is specifically is, does it increase the risk of ART resistance developing?
Yeah, so so let me start. There are a handful of cases. So this is not yet, where one can say, well, this is the definitive outcome. What I think is worrying everybody more is just masking of infection. So these individuals are actually, they have HIV, but we're unaware of it. So they're continuing to be on a monotherapy. And of course, that does lead to K65R integrase inhibitors. So we have seen some integrase inhibitor resistance in these individuals. So I think that is the big worry is, and then it takes a little bit of time, even after they've stopped the caballet, before antibodies can occur and people can be diagnosed. So I think that is what has got the wind up on this. So I think what the outcome is, we probably won't use NAT testing here just because that adds a huge difficulty to it. But we will really have to train people to be sure that they are dealing with somebody who is HIV negative, using a 4th generation, test where possible, and rather resorting to a PEP to PrEP kind of approach if there's any concern about recent exposure. So, that is, so the Levi syndrome, again, just to reiterate to people, it's a term that was coined by the lab at JHU, who did a lot of the 083 and 084 testing. This is where, because the injection was started before somebody had developed antibodies, they have a very low viral load, and don't create antibodies as a result, and therefore their HIV infection goes under the radar.
Yeah. And then maybe one thing before we let you go is just a person's left a comment about the possibility of pairing injectable contraception with PrEP. I know that's obviously something that has been discussed and looked into, but that's quite exciting. I don't know if you've got any feelings on that, or any breaking news. Or
Yeah, very exciting. So those studies are underway at the moment to say, can we, because obviously a 3-monthly depot and a 2-monthly PrEP agent is out of sync. So how, and so those studies are looking to see how we can synchronize that a little bit better, as well as ultimately, I think, get MPTs where we'll see combinations of these things. So I think the future is ripe with potential, and it's an exciting time to be alive. And I think there's a chance we can actually get those rates down for the first time in 2 decades, which I think is really exciting.
Exciting stuff. I endorse that entirely. So thank you very much, and a real privilege to hear from you. Thank you so much for giving me time today, and so many good comments being sent on my WhatsApp, etc. So thank you very much for all your time and expertise.
Real pleasure, Jeremy, and best of luck to everyone. So nice to see everyone. Take care.
Cheers. Bye.